GP has referred a patient who is a middle-aged woman with a tenderness surrounding the nail of the third finger of the right hand. As per the history, she has received a manicure 3 days prior to the onset of symptoms. The differential can be herpetic Whitlow, acute paronychia, chronic paronychia. A physical examination is performed. The periungual area of the affected digit appears erythematous and swollen and has tender to palpate over the radial paronychial fold and eponychium. There is also elevation of proximal nail bed with pus extruding out. The diagnosis is acute paronychia. Acute paronychia is an infection of the soft tissue fold surrounding the fingernail. The clinical presentation initially consists of localized tenderness in the paronychial region with subsequent erythema, swelling and fluctuance. Frank drainage and elevation of the nail plate are also seen. Acute paronychia are often seen in nail biters, as well as after manicure or in ingrowing toenails. The etiology of such infection is a break of the soft tissue seal on the dorsal periphery of the nail, allowing entry, colonization, and abscess formation of the offending organism. The infection begins in the lateral paronychial fold and may spread to involve the proximal nail fold, that is eponychium. In several cases, the lesion may reach the contralateral paronychia and is termed as a run around or a horseshoe infection. Such a paronychia is essential as infected abscess. Different treatment typically requires surgical drainage. Typically, Staph aureus is the common organism. Chronic paronychia are persistent indurating infection of the eponychium and present somewhat different from acute paronychia. It's typically seen in people whose hands are chronically exposed to water or a detergent and alkali, such as cleaning workers, bartenders, and kitchen staff. The etiology is thought to involve an initial bacterial infection, typically followed by superinfection and colonization of eponychium with a fungus called Candida albicans. There is a subsequent episode of inflammation and drainage, as well as fibrosis and thickening of the eponychium, secondary to the chronic low-grade inflammatory response. The patient presents with less severe erythema and fluctuance than acute paronychia and typically does not report as much localized tenderness. A typical sign of chronic paronychia is the appearance of longitudinal grooves on the dorsal surface of the nail plate, secondary to the long-term damage to the germinal tissue of the eponychium. Both acute and chronic paronychia has been noted with the increased incidence with diabetes, immunocompromised patients, and those on retroviral therapy. One of the most important antidote to distinction from paronychia is herpetic Whitlow, a self-limiting viral infection of the fingertip caused by herpes simplex, transmitted skin-to-skin contact, and is often seen in medical and dental personnels. As with paronychia, herpetic Whitlow may also present with swelling and erythema, though typically patients have disproportionately greater pain than in case of bacterial infections. Vesicles develop. As previously discussed, it needs a Tazang test, but diagnosis is made clinically. It is important to distinguish herpetic Whitlow from bacterial infection as doesn't require any surgical intervention and is a major contraindication to operate. A non-surgical treatment of acute paronychia should be attempted only in the earliest stages, when the infection has not progressed to more than a mild localized erythema or swelling. In such case, a regimen of oral antibiotics for Staphylococcus aureus coverage, such as doxycycline, 250 mg to 500 mg Q6 hourly, or fluoxetine, along with warm soak saline soaks, and rest may be adequate. However, by the time the patient comes present to the physician, there is already an abscess formation and fluctuant requiring drainage. Conservative treatment of Paronychia by use of topical or systemic antibiotics or antifungal agent has almost universally been unsuccessful. It is thought that the process of fibrosis and chronic injury in the aponychium leads to diminished vascular supply and decreased delivery of such drugs. As previously discussed, herpetic whitlow should generally be treated conservatively with typically run a self-limiting course of 21 days. A notable exception is when the bacterial superinfection happens and abscess formation develops. In such cases, abscess may be carefully drained with systemic acyclovir administered to reduce the likelihood of complications. The goal of surgical intervention in Paronychia is to allow thorough drainage of the collection. At the same time, however, it is imperative that invasion of the nail bed should be kept to the minimum to avoid future growth deformities. All the procedures described may typically be performed under a digital nerve block. In case where there is only involvement of one side of the nail fold, a true incision is not necessary. A number 11 or number 15 blade is used to completely lift the paronychium from the nail plate, opening the abscess in the nail fold and allowing drainage. Care must be taken to direct the sharp edge of the scalpel towards the paronychial fold and away from the nail bed to allow injury of the nail matrix that may result in scarring and growth deformities. If there is involvement of nail bed, it is best to remove the affected side of nail plate using a Freyer elevator to generally separate the lateral third of the nail from the nail bed, and then use a small pair of scissors to make a longitudinal incision and remove the nail plate. When there is involved aponychium and proximal nail in addition to the lateral fold, a single incision is made beginning at the midpoint of the paronychial fold and proceeding proximally through the aponychium to reach the base of the nail. The soft tissues are elevated and the proximal third of the nail is bluntly separated and excised with scissors. In severe cases where a run around or a horseshoe abscess has developed involving both sides of the finger, similar incision is made on opposite side as well, and the entire aponychium is elevated. Chronic paronychias are treated somewhat differently. Kieser and Eaton describe a technique of aponychial marsupialization that has highly effective at clearing the persistent infection. A crescent of tissue 1 mm proximal to the aponychial fold and 5 mm in width at its largest point is removed along with its subcutaneous tissue, taking care not to penetrate so deep to encroach the germinal nail matrix. Bender and Lane subsequently reported a success by removing only superficial soft tissue and excising the nail plate in case where it was involved. We agree that the latter approach provides adequate treatment while minimizing unnecessary trauma to the nail bed. In all of the above cases, the wound is thoroughly irrigated and packed with plain gauze and non-adherent dressing, and antibiotic regimen is begun, and the dressing is kept for 48 to 72 hours, at which point warm saline soaks are regularly performed until the irritation subsides.